This is LiveWell Talk on St. Luke's Transitional Care Center. I'm Dr. Dustin Arnold, Chief Medical Officer at Unity Point Health, St. Luke's Hospital. Joining me today, or returning to the program, is Dr. Clete Younger, Unity Point Clinic Family Medicine Physician and Medical Director of St. Luke's Transitional Care Center. To discuss who we serve at the center, our long-term care options, and what new options we have, as well as availability and how to select the right place for your loved one's healing journey. Dr. Younger, welcome back.
Thank you very much.
Second podcast, right? No, you've done a couple.
Might be four.
Yeah. You're a veteran. Award-winning podcast. Sorry, I forgot to put that tagline in there. How you been?
It's been good. We're evolving from the the 3 years of COVID dominating healthcare, and now I feel like we're getting back to where we can actually focus on other things. There was so much of all hands on deck to get past the pandemic. It's nice to be able to get back to really focusing on health and getting people healthier as opposed to just surviving the pandemic.
Well, I want to start by complimenting you and your team and the groundwork that you did early on in the pandemic to set end-of-life care goals for patients that would probably not have survived a hospitalization if they were admitted. And I think that was a huge impact to the community, both hospitals, and I know Mercy is grateful as well, because that did allow resource management to be a little bit more flexible than perhaps it could have been. So congratulations to you and your team. I just want to recognize that.
Thank you.
But first of all, you're like me. You're medical director of like 7,000 things, right?
8 nursing facilities.
8 nursing facilities. Wow.
Hospice, and then I work in my family medicine clinic too.
Right. Wow. That's amazing. And how many nurse practitioners are on your team now?
We have 3 nurse practitioners that are full-time doing post-acute care.
Wow. That's phenomenal.
But we are very blessed in that they're very experienced. They all were critical care nurses before they became nurse practitioners. So they're very versed at taking care of very sick patients. So they transitioned into the post-acute role very well. And we actually have a great, happy team that works really well together. We're really tight, and that helps a lot because, I don't think we experience any burnout working together at all. Even on hard days, everybody gets along so well. We're just not burned out. And that allows us to, be really efficient and take on hard things and not have that, affect what we're doing.
Well, I've often said it's those hard days where you go home and go, hey, they needed me today. Like if everything just goes perfect, you're like, God, I could have really called in today and, done it over the phone, really. Right.
Yeah.
So it's nice when they need you. But Transitional Care Center out on Council Street. Is that Cedar Rapids or Robbins?
It is technically Cedar Rapids. It's kind of wrapped in with Robbins and Hiawatha.
Yeah,
it's interesting. The map is interesting there. So.
I'm a Robbins resident, so proudly, in a Hiawatha hometown. So very familiar with that area. When was it built?
So it opened in July of 2019.
2019, so pre-pandemic.
Pre-pandemic.
Yep. And then it has the capacity for how many?
We have 46 beds.
46 beds. Now tell us about what the Transition Center does, and what primary patient population is it focusing on?
So we're really looking at the patient that has had an acute hospitalization that needs a prolonged course of monitoring. So there's been a lot of push in the United States to try to shorten hospitalizations, just to use the resources we have in the hospital appropriately, but then start moving people to different levels of care. Even though we have rehabilitation like physical therapy during a hospitalization, that's really not necessarily the primary goal. It's really stabilizing the medical condition. And when patients move from the hospital to skilled rehab, which is what we do at the TCC, that increases the number of hours of rehab that a patient gets as far as strengthening, moving around, and doing those sorts of activities, because we have a longer period of time to work with the patient. So, our length of stay is somewhere between 12 and 14 days. You can obviously do a lot different with therapy in a 12-day period of time than you could in just a 24 or 48-hour hospitalization. And that's really where we have a lot of expertise, is the multiple modalities with therapy, with speech, occupational, and physical physical therapy to work on patient strengthening. And then also there's certain medical conditions sometimes that when a patient leaves the hospital, it's better than when it was what it was in the hospital, but it's still unstable. And there's risk of a medical condition deteriorating, getting worse, or changing. And by coming to a skilled stay, we're able to continue to monitor those medical issues and fix things if they deteriorate. If a new problem develops, which is common after somebody's been hospitalized, we can address that new problem and treat it. And it gives a buffer between the hospitalization and returning to home or whatever home is going to be after that for us to stabilize people.
I've been had this mantra my whole career, and so I was a medical student, and I remember reading a small study from Great Britain, National Health Service, and they gave mid 90s, right, early 90s, and they gave patients self-addressed postal cards, and they said they went home after hospitalization. They said, you put this card in the mail every day that you don't feel like you're back to yourself, and quit doing it when you feel like you're back to yourself. And it turned out for about every day you were in the hospital, it took 3 days to get your strength back at home. And I've used that kind of formula in prepping patients my whole career. And it's pretty accurate, really. If you're in the hospital for, 5 days, it's going to take you 15 days at home to finally get back. It's not going to happen quickly. You're not just going to roll out of here.
Yeah, I agree.
And feel that you're back to normal. I don't know, in your practice, have you had the opportunity to take care of any old physicians?
I have. That's actually one of the most challenging patients I've ever taken care of was a family physician who had Parkinson's disease in a nursing facility.
Wow.
Because you could see that person that was you in them.
Yeah.
And that was one of the hardest patients I've ever taken care of.
I had a patient that was in his late 90s when I took care of him. This was in Grinnell, and he was a retired internal medicine doctor. But he would just fascinate me with these stories. If you had an injury, particularly a heart attack, they'd put you to bed rest for a month. That was the treatment. Oh, you've just had pneumia. You need to lay in bed for a month.
Yeah, it's crazy
and
to
recover.
Think. We're the exact opposite.
Yeah, and so, and I always think about those MRIs of the astronauts when they're in a weightless environment and how their muscles atrophy.
Mm-hmm.
Now, it's not synonymous, but it makes you think about if you just, and I say this, maybe you'll disagree or agree. If you just took a healthy 90-year-old and said, lay in bed for 4 days, they're going to be deconditioned on day 5.
Oh, yeah. I mean, you could set somebody back and they'd never recover.
Yeah.
You may have shifted somebody's baseline.
Yeah.
Even with that.
And that's then now you throw a pneumonia and a bladder infection and, a TIA or a small stroke on top of that, and it even gets worse. So, I think this concept of that transitional back to home is one that, particularly as hospital medicine, it was neglected for a long period of time. I think since you've been in practice and your leadership certainly has put it forefront, but there was a time I don't think it was really well thought out, that post-acute.
Yeah. I mean, the feedback we get quite a bit from patients oh my gosh, they're making me do all this stuff. Because even though there's dedicated times of therapy, people don't realize there's all the other stuff that we make people do. You have to walk to dinner. And if we want you to walk longer, we'll put you in a room farther away from the dining room in order to so those are therapeutic things too.
Right.
There's people, they're being pushed all day to do different things aside even just from their therapy interactions.
Yeah. They sleep better at night, though, right? I mean,
yeah,
I do.
And we talk a lot about too, everybody wants to be home, and nobody wants to, not be at home. But really, we are trying to maximize every moment of time they're there because we want them to leave our facility with the most strength they've gained or the stable medical condition that we can get to. And it takes a lot of pressing, and people are mentally get kind of fatigued with that. But the outcomes are better if you're able to get the most out of your time there when you're
fascinating
in that setting.
And so. What other, physical therapy comes to mind, occupational therapy. What other therapies and services does the Transitional Care Center provide?
So speech therapy is a big part of it too.
Speech, okay.
And when people hear speech, they often think, oh, it's just about swallowing. It's not. Speech therapy actually encompasses a lot of cognitive testing. So our speech therapists do cognitive tests on our patients, and that really helps kind of dictate what's the expectation going forward. Unfortunately, a hospitalization in a skilled stay is often a time where families start to rethink, where are we going? Is it safe for mom or dad or my parents to still live in this home, for example? And so speech therapy gets involved with us because they're able to help us with that cognitive testing to correlate with the physical functioning and medical functioning so that we can help be predictive of, where is the best place for this person to go. Unfortunately, in the United States, a lot of times people choose to go from home to a higher level of care after they've broken something or got really sick.
I have a saying, nobody goes to rehab halfway to rock bottom,
Mm-hmm.
right? You don't wake up one day and say, gosh, I'm halfway to rock bottom. I better go to rehab.
Mm-hmm.
No, you completely hit rock bottom and you're like, whoa, I have a problem here. Same with healthcare. Mom is, and mom might not be agreeable to having that conversation
Mm-hmm.
until she breaks her hip.
Yeah.
And that's human nature.
Mm-hmm.
And I never get frustrated or surprised at that with patients. That's just the way we are. It's the way we're wired. But you're right. A lot of it happens late in the game.
Yeah. We do spend a lot of time on that. One of the things that's unique about our program too, with our post-acute program, is our nurse practitioners, unlike a lot of other parts of healthcare, actually don't have any production part of their salary at all. They're totally salaried. And so if we need to spend 2 hours talking to a family, we spend 2 hours talking to a family.
Yeah.
There's no 15 minutes. I got to go to this next place and next place. We have total flexibility. And so that allows us to have a lot of hard conversations. And the NPs on our team really are focused on, they want to have those discussions with families along the way. And so that's one of the ways we think that we're successful, is not just the acute medical stuff, stabilizing the therapy part, but really spending the time with patients and families in order to, let's make a plan for what's going to happen next. This hip fracture is a sentinel moment in your life to think about. Maybe living in a split level home with 3 sets of stairs is not the best option. Let's talk about what else we can do. And then we can complement, our discussion about somebody's medical situation with social work, and then the community resources that we have access to be like, if we can't live here, where can we live that we still have a choice in wanting to be there?
Yeah, that's, I'll be 54 coming up here. And you start thinking about that. Oh, can I live in this house when I'm 70?
I built a new home 5 years ago, and our main floor has no stairs. There's no stairs from our garage. It's completely flat. So my wife and I could live there and not have to use a single stair. Just because, in my experience, stairs are bad because we see a lot of issues with stairs. But yeah, you have to think about that.
Yeah, you start wondering about that. And we have some good friends that they built a home that, they're about the same age as me. And I remember when they built it, he was like, yeah, I built it flat, so we could live there. And I was like, oh my gosh, I'm not even thinking about that stuff,
Mm-hmm.
Yeah. So that's
because it's a reality. Like, somebody who lives in a home with stairs, there will be a point when you cannot live there. That is a hard stop. If you have a bedroom on a different floor than your main level, that is not sustainable. Either you need a chairlift or you're going to have to go somewhere else. Nobody can live in a house with stairs forever. It's interesting.
Yes, that is. That's I can just hear the physical therapist talking out on the floors when they're like, well, they have stairs at home, and that's puts it in a whole nother risk category.
It does.
As far as getting them back home.
Mm-hmm.
Now, occupational therapy, if I could go back and do it, I think I'd be an occupational therapist because they do a lot of clever things. I just think it's so cool. But, sometimes patients say, well, I don't have a job. I'm retired. No, they're not here to teach you how to do a job. It's not vocational therapy. It's occupational therapy. Occupational therapy is out there as well.
Yep. We have PT, OT, and speech.
Yeah.
That's and all those modalities are involved with every patient. So
yeah,
when they come out there, they get assessed by everyone when they come.
Now, we were talking prior to the podcast. There's going to be a long-term care option out at the transitional care unit. Tell us about that. How is that coming about?
So in Iowa, if you were to go across the state, most skilled rehab is done in long-term nursing facilities. So most facilities have a population of patients that live there for a period of time, and then they also will see post-hospital patients for a skilled stay. When we first kind of had the idea, and Peg Bradkey and her, kind of vision when she did this back in 2017 and 18 before we built it, was to try to create a facility where it was skilled patients only. And that was unique. It's the only facility that really ever did that in the state of Iowa. We we, of course, opened in July of 2019, and the whole healthcare world got turned upside down in 2020. And so that's had to kind of make us think about like that model of care and how our population has changed and what the expectations from families are. So instead of having an all-skilled facility, we're actually trying to create some sort of long-term component to our facility. Because one, we're not using the beds that we have, and that's not good. We have our nurse practitioner team based in the facility. It's branded under Unity Point. Like, we should actually try to serve as many patients as possible.
Right.
And if the use of skilled care in the United States has changed because of the pandemic and managed care, those are two big reasons they've changed how we do skilled rehab, then we should really then try to maximize the beds we have in this high quality facility to take care of patients long-term too. So where we weren't really open to that, several years ago, now we're going to try to have a consistent population of patients that are there for long-term care so that we can maximize, that experience at the TCC. We'll still have lots of skilled patients coming through, but we will have, a subset of the building that's dedicated to long-term care as well. And we do that in every other building. So the other 7 buildings that I work at with my nurse practitioner team, all of those buildings have long-term and short-term patients.
Right.
So it's something we're experienced in. We're just kind of expanding that to the TCC so that it can do both as well.
Well, it makes sense. It allows greater degree of flexibility.
And a lot of patients come to the TCC and want to stay. We would kind of do that on a one-off basis over the last 4 years, but now we're going to, try to maybe market that a little bit more. Like, you've had a good experience here with your skilled stay.
You
need a higher level of care.
It's a beautiful facility.
Mm-hmm.
Beautiful facility. Let's talk about the nurse practitioners. I hired Julie Shaw to work at Manor Care in the 2006, 2007. And so she was just based, we had a nurse practitioner working there, and that was to complement the hospitalist program. But now you've taken it to the whole next level. Tell us about your team. You have 3.
Yeah, so 3 nurse practitioners. They all worked in high-level healthcare
That's
before.
What you said, yeah.
2 of them are critical care, and then they both got their geriatric nurse practitioner degree. Our other nurse practitioner, she worked in Mercy Hospice for 14 years, and then got her a nurse practitioner degree. So all of them had a lot of nursing experience, which is actually really good in a skilled nursing facility, because I'm not a nurse, and there's a lot of stuff I don't know about nursing and about how to care for patients. Like, there's all sorts of how to move a patient the right way, how you do things with different parts of people's bodies that nurses do that I don't know. So having these nurse practitioners is so good because they have the medical knowledge like a doctor, but that they have the experience of a nurse, and it's great to combine them together.
That's so funny because I'm a nice guy, right? And so when I'm making rounds and my patient needs to be moved, I'm like, or they're transition a patient, I'm not just going to stand there. I'm going to help. And so often the nurses on the floors are like, just get the hell out of the way. You are in the way. You don't know what you're doing. And I don't.
Right, because we haven't had the experience.
They stand back and they're just like, and they make it look so easy.
Yeah, so I love having their nursing background.
Yeah.
Because I'll ask them questions and be like, how do you guys do this? Or why is this not working? I don't understand. And they're able to kind of describe that. And so having that nursing experience first is fantastic. And now, they've all been in practice in our post-acute program all day, every day for, a minimum of 3 years and some up to 8 years. So just having that volume of that subset of patient population, the experience is unbelievable. And we have a shared kind of space where we have an office, and there's nothing like that, because if you have an odd situation, the best thing to be able to do as a physician is turn to your colleague and be like, this is what's going on. What do you think about this?
Yeah, especially early in your career.
Yeah. To be able to bounce stuff off people or users' experience. So we're actually, the bigger the team, gets, now there's 4 of us working together, even the better, because we have all this knowledge base together and I've seen that exact thing. This is what you should do. This is what my outcome was. So it's been so helpful as it's grown. So now that we, are in 8 facilities with my medical directorship, but we actually see patients in 11 or 12 different facilities, we're able to combine all that knowledge together. And we know a lot of the staff in other facilities now, and we can collaborate with them, and that's made it easier too. They know what to expect from us when we're seeing patients, and so that's made it a lot more efficient, and just really great people that we've been able to work with too.
Yeah, I think I've said this about inpatient medicine, and applies to nursing home medicine as well. It's nurse-driven, physician-guided, where your clinic is the other way around. It's physician-driven, nurse-guided. That patient doesn't move through clinic till they touch you.
Yeah.
And it's 2 different problem-solving skills. You got to think about it differently, and it's interesting that you've had that same experience in your career. Well, Dr. Younger, we've talked about all positive things, but there's a real sort of kind of dread of going to a nursing home or being sent to a nursing home. But talk about that, how people approach that and how you guide people to making that decision to have that, whether it's extended care, skilled care, intermediate care. Tell us about how does that what's been your experience in talking to patients about moving to a nursing home?
One of the things that's interesting is that as we've lived longer, we can stabilize medical problems longer, but then your functional decline still occurs associated with aging. So the reality is that people just lose function to a point where they need more assistance. And that can occur in assisted living, or sometimes people need, long-term nursing care. Then it's about how can we make that the best experience possible for them? So I think understanding that, a patient individually sometimes will feel like I'm being sent there, but really the people around you, like, our nurses, our team, like, we're just trying to make the best experience, right? We don't want people to suffer. We want people to have the best experience they can. And I think that is a core tenet of anybody who works in long-term care. As it's intimidating to go to a nursing home right away, the longer you're in there, you really see that, like, everybody is there who's compassionate about, let's make this person's life, what they have at this point, the best that it can be. And one thing that's interesting about, hospital nurses versus long-term care nurses, the relationships are an important thing. As a long-term care nurse, if you work 40 hours or 50 hours in a nursing facility every week, your home is in that facility.
Right.
And you will see long-term care nurses really appreciate those relationships. And they appreciate knowing a patient, seeing the same person every day, having those consistent relationships. And that's different than what you see in the hospital, where things are turning over every 2 days and you have new people all the time. And there's definitely personality types where that works very well for them. But a long-term care nurse, they want a relationship long-term. They want to know somebody for a long time because that's basically their home. They spend as much time at that facility taking care of those residents than they do at home with their own family and their own kids. So you will see those personality types get there. And I think until you've really had a lot of experience in long-term nursing, you don't understand that, like, this person who is the nurse for my dad actually probably cares about them almost as much as I do.
Oh, yeah.
Because they've gone there with the idea this is a home-like environment. So I think approaching, as a family approaching that idea of long-term nursing, I think approaching it that this is different than the hospital. And these people are here because they like long-term relationships and they want to take care of my loved ones and they want to make the best experience possible for them. And it's going to be different than what you see in the hospital, but that's the whole point of that. And really trying to get to know the staff because they're your family too now, because they're with you, and going at it from that perspective of, now we have a new family, we just have to adapt to this a little bit, let's make it the best that we can.
Yeah. And as a physician, when you get my experience, when I get a phone call from a nursing home nurse that sees that patient all day every day, and they say the patient doesn't look right or doesn't feel well, I'm like, yeah, they don't. It's you do get a sense of ownership and community.
Mm-hmm.
You really get a sense of community.
Yeah, people are very prideful for where they work.
Yeah.
They want their place to be the best because that's their home.
Yeah,
yeah,
absolutely. That's interesting. Well, thanks for joining me again today.
Mm-hmm.
And once again, Dr. Clete Younger, who is with Unity Point Family Medicine Physician at the Medical District. Is it the Medical District?
Family Medicine Medical District.
Family Medicine Medical District. And also medical director of just about everything, but including St. Luke's Transitional Care Center. For more information on short-term rehabilitation as well as long-term nursing services provided at the center, call 319-366-8701. Thank you for listening to LiveWell Talk On. If you enjoyed this episode, don't forget to subscribe, and if you want to spread the word, please give us a 5-star review and tell your family, friends, neighbors, strangers about our podcast. We're available on Apple Podcasts, Spotify, Pandora, or wherever you get your podcast. Until next time, be well.